Hi dear students, I'm Dr. Bahir, lecturer in the College of Pharmacy, University of Mustansiriya Department of Pharmacology and Toxicology. Our lecture in this day related to the drugs used for treatment of heart failure. As you know, that heart failure related to the reduction in the cardiac output of our body, and heart failure associated with so many signs and symptoms related to that reduction in the ejaculation fraction. As a compensatory mechanism for reduction in the heart failure, we have about four compensatory mechanisms in our body. The first one related to the increase in the sympathetic activity, as increase preload or venous return, by increase the central venous pressure as a result of compensatory mechanism. The second one related to the activation of renin angiotensin aldosterone system, and this associated with increase afterload or peripheral vascular resistance because increased angiotensin is due to the renal hypoperfusion. The third mechanism related to the myocardial hypertrophy, and this associated with increase the chamber size or thickness of our ventricles and associated with remodeling. The fourth mechanism or compensatory mechanism is called the acute or decompensated heart failure, and this is the end stage of the heart failure. Also, we can classify heart failure according to the systolic failure, or what we call it the heart failure associated with reduced ejection fraction, and the other type is the diastolic heart failure and associated with preserved ejection fraction. The strategy for management of heart failure related to decrease the dietary intake of sodium and limitation of fluid using positive inotropics and avoid drugs that precipitate or exacerbate the heart failure, such as non-steroidal anti-inflammatory drugs and other negative inotropic drugs like calcium channel blockers. These are drugs that can control or manage heart failure. We have about seven groups. The renin angiotensin system blockers, we mean by it ACE inhibitors like captopril, angiotensin receptor blockers like candesartan, beta blockers like atenolol, diuretics like furosemide, direct vasodilators like hydralazine and sodium nitroprusside, inotropic agents like amrinone, digoxin, and dobutamine, and the last one is the aldosterone antagonist like spironolactone. This slide represents the phases or electrical phases of the cardiomyocytes. We have four phases, starting from the zero phase, which is the fast, the fast upstroke phase, where the sodium channel open as a fast channel, and there is upstroke, and the current is blocked by some drugs like anti-arrhythmic agents like quinidine. The phase 1, which is the partial repolarization phase, is rapid phase of repolarization where the potassium channel rapidly open and close. The phase 2 is called the plateau phase where the calcium channel voltage sensitive calcium channel is open and there is a balance that slows the outward or polarized leak of potassium. The phase 3, sorry, is the repolarization phase where the calcium channel is closed and potassium channel open, associated with repolarization. The first phase is phase 4, which is called the forward current, where an increase in the sodium permanently and spontaneous depolarization preparing for the next action potential. This scheme represents how the cardiomyocytes contract. The important role here is for intracellular calcium, where calcium can enter to the cytoplasm from the outside of the cell, or after release from the storage site from mitochondria or endoplasmic reticulum, and increasing the calcium concentration will effect on myosin light chain for contraction of the muscle. Also, there is a regulation of the level of calcium within so many pumps present within the cell membrane of cardiomyocytes, like sodium calcium exchanger and sodium potassium ATP pump. So, in this scheme, we will clarify the pathogenicity of cardiac failure. We can see that the patients with cardiac failure associated with reduction of the cardiac output, and so decrease afterload, decrease blood pressure, so reduction in the renal blood flow. Compensatory mechanism number one, as we said, is the overactivation of renin-angiotensin 2 system and aldosterone, ending with increased sodium water retention, and as a result is edema, peripherally or pulmonary edema. On the other side, in cardiac failure patients, there is an increase in the venous pressure and sodium water retention. So here we have an increase in the preload, and as a compensatory mechanism, uh, also there is overactivation of the sympathetic activity, ending with interfering with the renal blood flow. The elevation in the venous pressure associated with increased capillary filtration and also ending with edema. This scheme also uh, summarize what we're talking about, the compensatory mechanism and the events associated with reduction in the cardiac output. As we said, decrease renal blood flow, decrease renin release and angiotensin, ending with an increase in the pre and afterload and remodeling. Also, there is a reduction in the cardiac sinus firing, compensatory mechanism, and overactivation in the sympathetic discharge, increased force and rate of contraction, and also end with the same results. So there is a elevation or increase in the pre and afterload and remodel. This end with increased cardiac output by compensatory mechanism, but this compensatory is transient. At the end, the compensatory cause damage to the uh, cardiomyocytes, and so called the decompensated or acute heart failure stage. Now we will start with the uh, group of drugs for management and control of heart failure. We will start with ACE inhibitors and ARB. This figure represents the mechanism of ACE inhibitor, where the angiotensinogen by renin converting to the angiotensin 1. So ACE inhibitor here will block the conversion of inactive angiotensin 1 to angiotensin 2. As angiotensin 2 decrease, there is reduction in the sympathetic nervous system, increase in the vasodilation of vascular smooth muscle, increase the level of bradykinin, and decrease retention of sodium and water. So decrease pre and after load and control by this way on cardiac failure. So there is some difference between ARB and ACE inhibitors. ARB usually indicated for those who cannot tolerate ACE inhibitor side effects like persistent dry cough and angioedema. So it is a good alternative for those suffering from the complications of ACE inhibitors. Also, we have aldosterone antagonists, which can be indicated for severe stage of heart failure by using spironolactone or eplerenone, and these drugs can decrease or control the remodeling that associated with heart failure of the cardiomyocytes. Right. We can see from this study that cumulative mortality rate is reduced by using one member of ACE inhibitor like enalapril compared with placebo. If we go through the beta blocker group, the mechanism for control of heart failure associated with decrease in the heart rate, decrease running, and decrease remodeling. So it is indicated for chronic stable heart failure by using a small dose. Good example we have carbidiol, which is a non-selective beta blocker associated also with blocking of alpha adrenoreceptors, and other examples like bisoprolol and metoprolol. Diuretics can also indicate for heart failure, specifically loop diuretics, as decrease both the pre and after load, and also they decrease the symptoms associated with uh, shortness of breath, paroxysmal nocturnal dyspnea, and orthopnea. The vaso and venodilators can also indicate it for heart failure. We usually combine the venodilator like nitrate with the arteriodilator like hydralazine to decrease both the pre and after load with those suffering from heart failure. So, what about the positive inotropic drugs? We have three members in this family. The first one is the digitalis glycosides like digitoxin and digoxin. And most of the positive inotropic drugs nowadays indicated for acute heart failure only because the survival rate decreased by using these drugs. The digitalis can be indicated and act for heart failure as they inhibit sodium potassium ATPase, so decrease the calcium efflux outside the cell membrane. This scheme represents how digitalis inhibit this pump and ending with increase the free calcium level within the cytoplasm of cardiomyocytes, ending with increased force of contraction. Also, digitalis have vagotonic activity, so cause bradycardia and decrease oxygen demand, and also decrease conductivity, so can indicate it for those suffering from atrial fibrillation associated with heart failure. Also, digitalis have neurohormonal inhibition by inhibiting sympathetic nervous system activity. So the main indication of digoxin or digitalis is for severe heart failure and for those suffering from severe yes heart failure, not for mild to moderate or those associated with just right heart failure alone. They may indicate for those suffering from left heart failure and severe cases because digoxin have so many adverse effects and require a specific antidote to detoxify its effect. How the positive inotropics and digitalis specifically or digoxin can control or manage the symptoms of heart failure. We can see the y-axis represent cardiac output, x-axis ventricular and diastolic pressure. The point A at which there is normal opening point in the healthy hearts. So the A represents healthy subjects. If we go past through point B, we can see initial reduction of contractility from A to B due to heart failure. So the cardiac output starts to decrease. Here the patient suffering from fatigue. If we go to step 3, we can see the ventricular and diastolic pressure increase from point B to C in an effort to maintain adequate cardiac output. Here the patient suffering from dyspnea. And if we go to the step 4, we after administration of digoxin as treatment, we can see the digoxin cause increased contractility from C to D, so lead to increased cardiac output and decrease the ventricular and diastolic pressure. This is slide also summarize what we're talking about. The green line represents normal subjects, good cardiac output, and less end diastolic fiber length. The red line represents compensatory response or treatment, and those without treatment suffering from the heart failure, which represented by the blue line. What about the difference between digoxin and digitoxin? We can see that digoxin have less protein binding, rapid onset of action, and shorter half-life, so it is preferred on digitoxin nowadays. The drug-drug interactions between digoxin and other drugs is so many. For example, amiodarone and erythromycin increase digitalis concentration, and this may occur during current therapy. So this enhances potential for cardiotoxicity. On the other side, some drugs like steroids, loop, and thiazide diuretics decrease the level of potassium in our body, so also enhance the potential for cardiac toxicity. Right. Another example on positive inotropics, we have what we call it the sympathomimetic drugs like dopamine and dobutamine. They're acting on the beta adrenergic receptors, activate adenylate cyclase, and so increase the cyclic AMP by and this ending with activation of the protein kinase, phosphorylation of calcium channels, and enhance the entrance of calcium to the cardiomyocyte, increase force of contraction. On the other hand, another positive inotropic, we have the phosphodiesterase inhibitors like milrinone, as inhibiting this enzyme, as inhibiting the converting or degradation of cyclic AMP to AMP, so increase the level of cyclic AMP, and as end result increase the force of contraction. So what about the order of therapy that's indicated for management of heart failure? From this slide we can see the simple cases can be managed by just diuretics. The mild or to moderate case can be managed by ACE inhibitors plus diuretics or digoxin plus diuretics. In the severe case, we can use triple therapy like digoxin plus diuretic and ACE inhibitors. This scheme or stepwise figure represents step up sorry figure represent the orders of therapy also. The stage 1 is the high risk with no symptoms of heart failure, so we have to reduce the risk factors and give patient some educations or instructions like sodium retention and water or fluid limitation. In the stage B, we can see the structural heart failure changes with no symptoms. We can start with ACE inhibitors or ARAB in all patients. Beta blocker can be selected for some patients. In the severe case, there is structural heart disease, previous or current symptoms. So ACE inhibitors, beta blocker can be given in all patients. Dietary sodium restriction also beneficial here with diuretics and digoxin. So, to summarize this chapter about heart failure, we can see the site of action for our drugs. The vasodilator drugs decrease preload and decrease central venous pressure. Positive inotropic act directly on the cardiomyocytes and increase force of contraction. The ACE inhibitor inhibit the formation of angiotensin II, while diuretics uh, decrease the sodium and water retention. So, at the ending of this chapter, our dear students can answer or understand these points. Describe the strategy and list major drug group used in treatment of acute heart failure and chronic failure. Describe mechanism of digitalis activity and major effects, and describe the nature and mechanism of digitalis toxic effects. List some positive inotropic drugs other than digitalis, and describe the beneficial effect of diuretics, vasodilator, ACE inhibitor, and other drugs. At the end, we can make self-assessment by answer question. Compensatory increase in heart rate and renin release that occur in heart failure may be alleviated by which of the following drugs? A. Milrinone. B. Digoxin. C. Dobutamine. D. Enalapril. And the last one is metoprolol. So, which is the correct answer? Thank you for your good listening and with best wishes. Goodbye.